Good evening. It is 7 o'clock, 1 minute past, and I'd like to take this opportunity to welcome all of you, dear colleagues. I see you already have more than 100 participants logged in. Let me first welcome you to this webinar marking the World Asthma Day. And I'd like to thank CIPLA who have put together this webinar, and Gombile who has organized the seminar tonight. Today we're celebrating World Asthma Day. The first World Asthma Day was held in 1998, and from then it has grown globally to be a major event celebrated each year as an advocacy and awareness in the field of asthma, to bring awareness among asthma patients. Today, PATS, together with our partners, the Forum for International Respiratory Society, recognize the World Asthma Day. Asthma is one of the most common non-communicable diseases in adults and in children globally. And in Africa, in many African countries, the prevalence is increasing in urban areas. Yet, it is still underdiagnosed, and access to effective management with inhaled therapy remains challenging. Today, we are celebrating the theme for asthma, uncovering asthma misconceptions. And this will address some of the barriers to control of asthma, which may be among the patients, the healthcare providers, the facilities, and the geographical challenges. The most important thing about asthma is to educate both the healthcare workers and the patients themselves. It is now my great pleasure to invite our first speaker on this topic to tell us about some of the myths and misconceptions and epidemiology of asthma in Africa. Dr. Bruce J. Kirenga from Kampala is the Chief Scientist, Research Officer and Director of Makerere University Lung Institute, Senior Lecturer in the Department of Medicine, Makerere University. He graduated from Makerere in the year 2002 and has had very lasting career in pulmonary medicine in the country. He has been in this forum before, and I think I've shared with him another webinar. So it's always a pleasure to have this Kabaka representative talking to us. So without wasting much time, let me introduce Bruce Kirenga to start the ball rolling immediately. Welcome, Dr. Bruce Kirenga.
Thank you very much, Dr. Roach, for that wonderful introduction. And thank you everyone for coming to this meeting. My task this evening is talk about asthma epidemiology and risk factors in the context of asthma misconceptions. I may not pull out one by one that this is a misconception, but through this lecture, you will get the facts and therefore check with yourself if you had a misconception or a misknowledge. This is the outline of the presentation. In the introduction, I will define asthma. I will talk about pathogenesis. I will talk about diagnosis and introduce to you our approach to diagnosis, where we talk of possible, probable, and evident asthma. Then we will talk about determinants and the burden of the disease. To start off the introduction, asthma is defined by GINA as a heterogeneous disease that is characterized by airway inflammation accompanied by recurrent or persistent symptoms, and the symptoms are wheeze, shortness of breath, chest tightness, and cough that vary in time, over time and intensity, together with airflow obstruction or limitation. This is a heavy definition, but the key thing is this is an airway disease that makes people have difficult to breathe, and the underlying problem is inflammation. And the other cardinal thing is that it is variable with the time, day, and intensity. I think that is key. In most cases, you could get an identifiable trigger, and these triggers could include exposure to pollutants, allergens, exercise, change in weather, or chest infection. Another thing also to note on asthma, since we are talking about facts, is that these symptoms could be absent for several weeks or even months, but doesn't mean asthma has gone away. They could come back either spontaneously or if they are triggered with something. In asthma diagnosis, the key element of diagnosis, that someone must have a respiratory problem. They must have a complaint for you to start the diagnostic cascade. These respiratory symptoms are of the characteristics I've described. They are variable in time and intensity. Second, there is evidence of airflow obstruction, which you can demonstrate by doing a test, or the documented evidence of earlier diagnosis of asthma or response to treatment. Now, this is a table from GINA 2017, but it's very important as you develop your asthma diagnostic thinking. We have first said that history of variable respiratory symptoms is key. And which are the symptoms? This is wheeze, shortness of breath, chest tightness, and cough. Now, these symptoms, they are of this type. There are generally more than one respiratory symptoms. It shouldn't be an isolated symptoms. They should occur varying over time and intensity. They are often worse at night or on waking. These symptoms are usually having a trigger, and symptoms appear or worsen with viral infection. So that is key. So as you create a diagnosis of asthma in your practice or in your head, you need to know these characteristics of the symptoms, not only the symptoms, but the characteristics of the symptoms. Then you confirm the airflow limitation, and this can be done either by demonstrating reversibility on spirometry. You can use exercise. You can also see if there's significant increase in lung function after treatment, usually 4 weeks. You can do a bronchial challenge test, or you can use exercise limitation. I have to mention here that our usual and simple PEF machine can also be used to demonstrate reversibility. So now, based on that, in our practice, we have come up with 3 levels of asthma diagnosis. So you'll find in our files, there are people, we say these ones have possible asthma. These are people who have symptoms alone. They have response to medications, and we have supportive evidence. That means they have family history, they have allergy, and they have responded to treatment before. You don't have anything else. They are just coming. They have these respiratory symptoms, which are characteristic. So we say you have possible asthma. Then we go down and look at probable asthma. Probable asthma, these are people who have possible asthma. They don't have any airflow limitation when you do the spirometry at the first time, but once you challenge them, you get a bronchodilator response. I have to repeat this. So you do your spirometry, it is normal. They only have symptoms. Don't stop there. Go and challenge them even if they have no obstruction. Should you get a 12% increase or 200 mils, then that is a higher evidence. We call that probable asthma. And of course, definite is where you have symptoms, you have reversibility, but you also have obstruction, airflow limitation. So those are 3 levels which help you to categorize these patients, and we think this is important. And down there, I have attached a review which discusses this from expert review of respiratory medicine, and we have found it to be useful. Now, the pathogenesis of asthma is a complex one, but this evening I will demonstrate that when we talk about asthma, we talk about eosinophils, we talk about mast cells, but there is a cool 9 cells involved in the cascade or the milieu of asthma once it is getting established within your lungs. First of all, the mast cells which produce histamides. These bring the allergy symptom, syndrome. The eosinophils create the inflammation. The T cells produce the interleukins, which worsen the inflammation. But look, the dendritic cells, these ones go and mobilize the allergens and hand them over to T cells to react even more. Then we have structural cells like epithelial cells. These ones produce cytokines and chemokine, which make the situation worse. Number 6, airway smooth muscle, which you think is just a bystander. It undergoes hyperplasia, hypertrophy, and also produces cytokines, which worsen inflammation. Then endothelial cells, increased recruitment of inflammatory cells. Fibroblasts, which you know very well, will now produce collagen, which causes airway swelling, and then the nerves add the fire by creating the bronchoconstriction and secretion. So now, all these things, if you look at them in this next slide, you can see that actually inside the airway, there is a lot going on. Your allergens, your pollutants are sitting in there and causing problems. At the mucosa, you can see the cells in there, the epithelial cells, are working, but deep down they send information to lymph nodes, to blood vessels, and bring in the T cell, the eosinophils, to come and add fire. And at the height of development of unestablished asthma syndrome, a lot is happening in these patients' airways, as can be seen. Now, asthma, as we have described it in this pathogenesis, may look like a single disease, but this is a syndrome which has many other things inside. The asthma syndrome has phenotypes and endotypes. The phenotypes is what we see outside. The endotypes are the mechanism of each group of asthma that is happening, and I will show that here in this slide. You can see the asthmatic patients who have a lot of symptoms. When you check their inflammation using pheno, they have no inflammation. They even don't have airflow obstruction. They only have symptoms. There are those ones who are obese. There are those ones who have eosinophilic asthma. There are those ones who have early onset atopic asthma. But as I will show you later, in Africa, we are seeing a lot of adult non-allergic asthma, and we need to find out what is happening. So in a way, when you have a group of asthma patients, when you are going to treat them, and you think of asthma alone in your head, that is half the story, because these patients are different depending on their phenotype. I will briefly talk about endotypes. The endotypes are the mechanisms. There's asthma, which is mediated by eosinophils. That is the commonest. But there's that one which there are no eosinophils, as I will show you later in the slide from our work from the ASAP program. So these mechanisms are also important because they help guide treatment. It is believed that people who have no eosinophilic asthma may not respond to steroids, which are our main of treatment. These patients may need other biological treatment based on the mechanism of the asthma that they have. Determinants, the determinants of asthma could be genetic, but could be environmental. But as we know, quite of the tropical infections, HIV, TB, are causing asthma in Africa, plus occupations. I will first of all talk about this environment genetic interactions. This is key, that people who have a genetic predisposition, once they meet the right trigger or offender in the environment in an infection, then they develop disease. In this slide here, this is published in the European Respiratory Journal last year. They have good evidence of asthma and the environment. They considered only particulate matter and the pollutants as you see them here. Now, if you look here, you can see this is concentration of the particulate matter. And this is, here is percentage of asthma from prevalence of asthma. You can actually see as the concentration of particulates increase, the prevalence of asthma increases, and that is significant. Look at nitrogen oxide, the same story. You look at smoking, the same story, positive correlation. So the environment is a very important factor. In Uganda, in one of our studies, which are published about 2 years ago, we compared, we wanted to see the role of a polluted city in the causation of asthma. So we got children, 200 from the capital city, 200 from a smaller city, and 200 from a village sub-county. You can actually see that children in the capital city, and the rural city and the smaller city, there is a correlation between the lung function of these children. In this slide, you look to see that the rural children have better lung function. If you adjust for their age and sex. Of course, we know rural children are smaller, they're a bit malnourished, but once you correct for those, they perform much better than the urban children. In the National Prevalence Survey, which we conducted, I think in 2016, we found a prevalence of asthma of about 11, but that's not the story we want to tell. Look at the association between biomass use and asthma, 2.204, that was the odds ratio, and urban residents. And that is key and locally to support that asthma is associated with the environment. We also went into deep in this survey to look at the issue of gender and age. That debate has been raging on. Asthma, is it more common in children? Is it more, in females or male? Here, we looked combined age and gender. And you can see in people who are young, that's up to 25 years, you see that females have more asthma than the males. This is the line for males. That continues, but when you get to the 25 to 34, you see the males now take over. But of course, the females come and take over. But the key point here, you can see that in the older age, the male take over, having more asthma, and they remain to have more asthma than females up to old age. And this supports the hypothesis of these hormones and all these other things, but we don't have time to go into that today. This is the story of adult onset asthma, which is a shocker from our studies. In the African Severe Asthma Program, looking at 1,700 asthma patients in Uganda, Kenya, and Ethiopia. These are the rates. 62% of patients developed their asthma after the age of 19, and this was very common in Ethiopia. So the reasons for this could be offenders which happen in adult life, which were not in childhood, and therefore suggesting that there are other environment drivers of the asthma burden in Africa. Now, looking at asthma and HIV, in Uganda, we looked at this in our national asthma survey, and we are comparing prevalence ratios of asthma between HIV positive and negative. And you can see overall, it was 1.7. So asthma, HIV was associated with asthma, and this was maintained at almost all the age groups up to those who are greater than 65. Occupational asthma, I will talk this as one of the risk factors. Africa is industrializing at a very high rate. That is very good, but we must start to prepare for occupational asthma, and this is asthma which is related to something that you are exposed to at your workplace. There are two types. The first one is what we call sensitizers. That means there's something allergic within your workplace. These are people who work with chemicals and large molecules. And that is one type of occupational asthma. The other one are irritants. These are non-allergic. You just inhale bad things within the workplace, dust, particles, and then you develop asthma. The mechanism are two. One, of course, you can imagine, the non-allergic is not mediated by IgE, and the allergic is mediated by IgE, and it can be treated the way you treat allergic asthma. But this irritant asthma, someone has inhaled dangerous things in their workplace. The management is different because this is not in the allergic asthma pathway. I will quickly talk about the burden of asthma, which we know. Here we talk about prevalence, mortality, and severe asthma. These figures are known to all of us. The number of people who have asthma globally is about over 300 million. We know that asthma is reducing in most developed countries, but coming up very seriously in developing countries. You can see in 1990, there were 74 million people with asthma in Africa, and by 2010, it had reached about 120 million. This is according to systematic review, which has been published. And of course, this could be worse by now. This is looking at asthma in the different countries, but the key point from here is you can see that symptomatic asthma is more common than doctor diagnosed asthma and clinical asthma, and this is the reflection of lack of diagnostic services for asthma and treatment. This graph has already been talked about. This is the prevalence of asthma in Uganda in our study, and we found it to be associated with urban residents and, of course, slightly more common in females, but you see the difference is not large. When you talk about diagnosis by symptoms, you can see that in Uganda, compared to the table I showed you from all over Africa, most of the asthma we found in the survey was symptomatic. Hardly anyone was on medication, and people had not been diagnosed. Asthma mortality, globally about 420,000 people died of asthma in 2016. But look at our data in Uganda. We followed up 449 asthmatics and registered a mortality of 3.7%. Now, if you consider the prevalence of 11 that we talked about, you can see that very many people are probably dying from asthma in Uganda than HIV, TB, and malaria combined. This is a review from one of our students. And as you can see in this graph, the asthma mortality is not anywhere to start going down. About severe asthma, I will quickly tell you that when you use the GINA classification, about 24% of asthmatics are on step 4 or 5, so therefore they have severe asthma. But if you consider difficult to treat asthma, that means they have about 17%, but those ones who are treatment resistant reduces to about 3.7. This is our experience in Uganda with severe asthma, where we did a study in Kenya, Ethiopia, and Uganda. And this is what we have found. These are the characteristics. Just to mention that this is a large cohort of asthmatics in Africa, and we have published this paper. People can look at it and see the characteristics. In terms of phenotypes, we also did phenotyping. We found that the phenotype has shown people who have high pheno, people who have high eosinophils, and people who have allergy. You can see up to 32.2%. In terms of control, I hope this is my last slide. In the severe asthma program that I talked about, you can see the level of asthma control in the 3 countries was low at the beginning of the study. We followed up these patients for about 2 years. When we started treating them, you see this improvement, a high jump by 3 months. We all registered high control, meaning that asthma can be controlled in Africa. However, another point to pick from this graph, after we went up, we actually did not improve a lot at 6 months, 9 months, and 12 months, suggesting that the concept of treatment-resistant asthma in Africa could be higher than elsewhere, probably in the range of about 15 to 20%. Thank you very much for listening to me.
Thank you very much, Bruce. Excellent as usual, and very much keeping to the time and to the point. Just to remind the participant that please, if you got any questions, put them on the Q&A chat, not on the chat box, the Q&A section, and we'll answer them at the end of the session, which will be conducted by Anne. Now we go straight to the next speaker. We have Dr. Ada Adeze Ayuk, who is going to talk to us about the same thing, but in a smaller age group. And we are pleased. She's a renowned pediatric pulmonologist and a serious researcher. She's been working on several aspects of asthma, and he's won many awards and done many papers, and he's currently a lecturer at the University College in Nigeria Medical School. He's going to talk to us about facts about asthma in sub-Saharan Africa, management principle. His CV is very long, and that will take a lot of our time. So I'd rather give you Dr. Adeze Ayuk to address us on facts about asthma in sub-Saharan Africa. Over to you, Dr. Ayub.
Thank you very much, and thank you for this opportunity for us to share knowledge together. Thank you for the sponsors and for the opportunity to be part of this. And this year we'll be looking at that theme of uncovering asthma misconception. And I'll be trying to look at facts about asthma in sub-Saharan Africa with the management principles in view. I have no conflict of interest relevant to this presentation, and I'll be handling this topic using the following outline. Bruce has spoken a lot and told us what asthma is. Just a reminder that it's a chronic disease. It involves the airway. We've also heard that the main symptoms are that of cough, wheezing, shortness of breath, and sometimes complaints of chest tightness.
Dr. Ada, can you put your presentation on a slideshow?
All right, so we have data that show there are real asthma management issues and a lot of misconceptions in sub-Saharan Africa. And some of them that relate to management issues is what we'll be talking about. Now, just a recap that Bruce has reminded us a lot about different interplays of factors in asthma. We know that the aim of anyone having asthma is to have control and avoid future risk. And that is looked at from the point of current clinical control. And what affects that is the current asthma severity, which is affected by disease activity, and the phenotypes Bruce has told us about, the eosinophilic, the neutrophilic. And of course, this is also spoken to by genetic factors, environmental factors. And all these have a lot to do with the outcome based on what treatment. So we're going to look at what are these management principles. Before we go into that, I want to tell us of a true story from Africa. Again, still trying to deal with misconception of about asthma. Wololo is a young girl of about 11 years from Ghana in a nomadic community, a rural community. And usually he has this ritual routine exorcism carried out on her. But during such exorcism actions, some doctors who were carrying out studies within that community found that this spirit of breathlessness being cast out of Wololo was actually asthma attack. They then administered bronchodilator, and the girl got relief. We'll continue this story later, but bear it in mind because of misconceptions about asthma. So talking about management principles, what are the 4 main management principles? One is you need to make sure it is asthma you're dealing with. You identify it to properly diagnose it. You can use symptom assessment like that given by the National Asthma Education Program expert and even GINA. You can also use objective tools. Bruce has told us about probable asthma and, confirmed asthma. So use objective tools like your spirometry. Remember, in this COVID era, you need to follow proper protocols. You can also use your asthma control questionnaire, the different tools to be able to assess asthma diagnosis and the control level. So in terms of diagnosis, NAPEP summary will tell us episodic symptoms of airway obstruction or hyperresponsiveness, which is at least partially reversible, and then you've excluded the alternative diagnosis. The methods will include a detailed medical examination, a focused respiratory system examination, and then a backup objective studies like spirometry. Once the child or the person is 5 years and above, you can actually begin to do things like spirometry and other tests if it's available to you. And of course, you may need additional studies if you need to exclude alternative diagnosis. What is the second management principle, which is what a lot of us, hamper on? That is that of pharmacologic therapy. And remember, this goes with correct use of adjuncts like spacers to deliver drugs, particularly in children. And then procedures like when you're using the pressurized metered dose inhalers, because some may not know how best to use it. Then, of course, the environmental factors. Bruce has made reference to some studies that have been done, and then comorbidities that may affect asthma in that patient. Of course, the fourth thing, which is a primary thing, is education, because education in asthma goes for partnership in asthma care. And part of the education is what we're doing today. As we educate ourselves more, we'll have less of misconception and misknowledge. So in terms of diagnosis, which was the first principle, this study, which looked at respiratory practice and impact of having trained health workers in the southern part of Nigeria, we found out that those who had ever had any formal training were really few. Up to 70% of participants in that study had never really had any formal or informal training on spirometry. And when asked about knowledge of existence of GINA, about 80% knew about GINA, but only half would use it or practice using it. And making diagnosis of asthma with additional lung function equipment, whether spirometry, whether peak flow meter, was only also possible or done by 50%. So that begins to show us how much we do in terms of objectively diagnosing asthma. In this other study that was done among pediatric residents, we also saw issues of confirming diagnosis with pulmonary function tests, where only 47% of participants would use either peak flow or spirometry to, confirm a diagnosis. Familiarity with peak flow meter was also much better compared with spirometer, because only about 18% were familiar with spirometer. The other aspects of management that are in the slide, we'll discuss them in subsequent slides. But I just wanted to bring out this point of health workers being conversant with objective measurements, objective tests that can help you confirm that this is truly asthma. What of pharmacologic management? And I use the dictum, keep your eye on the money. Why do I say that? Asthma can be acute asthma can be chronic stable asthma. Okay, so the bane of management we'll see is actually the corticosteroids. That's why I say keep your eye on the money. Most of the talk we'll be talking about when we talk of pharmacological management, we may not go into the metals and things, the aminophyllines, we may just be talking about the steroids. So anti-inflammatory agents, the corticosteroids can have the oral and the inhaled corticosteroid. But what's our experience with it? Now, if you look at the GINA has the 2021 GINA is available now. You can download it online. But what I want to bring out here is that if you look at all the steps, this is the box that describes how you treat adults and adolescents 12 years and above. You can see that every step of the way in terms of pharmacologic management involved using an inhaled corticosteroid. Step 1, step 2, step 3, step 4, step 5. And even as a preferred reliever, that is the teaching, that is the evidence-based medicine now, that if you need to treat someone, even when they have an acute attack, you need to consider using an ICS with a combination of the long-acting beta agonist, and in this case, one that has short onset of action, such as the formoterol. That is what they call the SMART approach. So that you can see that keeping your eye on the money, which is your steroid all the way in every stage of management for asthma. What of children 6 to 11 years? You can also see that emphasis there is still use of steroid. ICS step 1, step 2, step 3, step 4, step 5. So that is the bane of management. What is, when you're then managing, you need to also consider comorbidities that may also be existing in the patient you're managing. You also need to review inhaler techniques. You need to check adherence of the medications you've given. And when considering where do you start? Oh, do you start low dose, medium dose, high dose? Supposing it comes at different stages. Take, for example, the person comes with symptoms twice a month or more, then you need to look at the guidelines to help you know where exactly to start based on the symptom or the presentation of the patient. And then when you talk of medium, high or low dose, what does that exactly mean? So you just don't say to your patient, oh, continue using your medications, 2 puffs BD or 1 puff daily. What does it mean to you? If it's a child between 6 years and 11 years, what may be medium dose, for example, will be different for what is medium dose if it was 12 years and older. The 12 years and older is considered within an adult range. Take, for example, you wanted to give budesonide. Medium dose, for example, is 200 to 400 microgram. Okay, then, but if it's for someone 12 years and above, that medium dose, you need to give 400 to 800. So we need to monitor our patients. We need to understand what we're giving. We need to understand what low dose means, medium dose means, high dose means. And again, depending on which type of steroid, which type of ICS you're prescribing for this patient. So the pharmacological management of asthma, long-term use of ICS are the cornerstone. Unfortunately, a lot of prescribers worldwide aren't aware about this knowledge, this information that ICS is the bane of treatment, or they are not able to give correct prescription. Others also afraid of use of steroids, and that is part of what will promote misconception. Take, for example, in this study done in Ethiopia, where we looked at they looked at the factors that contributed to underutilization of inhaled corticosteroid. You can see that up to 10% were contributed by either fear of side effects or physician recommending not to use ICS. And sometimes those physicians may also be because of steroidophobia. The other reasons we'll see and as we go along, but that issue of having misconceptions about use of ICS is a major factor, both for the patients and even for the prescribers. In this other study, still in Ethiopia, from the Jimma University, where adult asthmatic patients were asked about their knowledge, attitude, and practice in use of their majority of them actually strongly agreed that asthma cannot be controlled. We know that asthma can be controlled. You may not have a cure. And some also think in one of the misconceptions that you can only control asthma if you use very high dose of steroids. But of course, that is not true. Most times, the bane of treatment is to use the lowest possible dose of inhaled corticosteroid that can keep the patient's asthma under control. So most times it can be controlled with low dose inhaled steroids. Remember, this is different from the ones you give as tablets. The inhaled corticosteroids, they come as microgram and you use it. So as a healthcare worker, as a healthcare provider, you need to monitor your patients regularly and titrate their medications. In this other, in that same study from that Jimma University, they were also asked if asthma medicines, if you take them until a particular time, then you can stop them. Again, that is a misconception. The idea is to try to use the lowest possible dose. You keep titrating till you get what can minimally be used to control the asthma. Again, that was a misconception in terms of treatment. Now, I want to move to these medications we tend to prescribe or we tend to use and look at sub-Saharan Africa. Are these medications available? Are these medications affordable? This meta-analysis or systemic review that was done in one of the studies, the first one was done in low and middle income countries. Malawi was one of the countries studied, and two essential medications, salbutamol and beclometasone, were on the essential medicine list. Availability of beclometasone was actually 0% in public sectors and about 38% in private sectors. And you needed up to 9 days wage to be able to afford a combination of both medications. In another study by Kiriba in Uganda, again, they had 17 medications in the list and 2 diagnostic tests. Availability again of the ICS LABA combination or the ICS were both less than 50%. Remember I said, keep your eye on the money. We're looking at mainly steroids and its availability and affordability. And now in some of the places you would need up to 17 days wage to be able to afford formoterol budesonide combination. And of course, availability of the tests will require up to 1 month's wage to be able to afford to do a spirometry in some of these countries. This other study is still in Uganda, where 196 health facilities were looked at. 2 essential medications were listed, beclometasone and salbutamol. Again, availability of beclometasone was very low, 1.5% in the centers studied. In another study where 21 sub-Saharan African countries were included, including 2 private retail pharmacies, 3 essential medications were listed, beclometasone, salbutamol, and budesonide. The availability of beclometasone was 0% in Burundi, Cameroon, Democratic Republic of Congo, Djibouti, and some of the sites that were surveyed. Affordability was also something else, because in some of the places like Guinea, you needed 3 months' wages to be able to afford to buy the innovator budesonide. And this, again, is not good enough. One of the studies in Ghana, Banyako et al., 3 essential medications were listed, ipratropium, beclometasone, and salbutamol. Again, what do we see when we keep our eye on the money? Beclometasone was, again, not very available. It was only available in 17% of the places studied. Desalu et al. In Nigeria had 6 classes of essential medication in the tertiary hospitals that they studied. Again, the ICS was only available in 5.9% of places. The combination ICS LABA was more available in up to 50% of places studied. But remember, in children particularly, if you follow the GINA step ladder approach, you start with ICS alone. And you can see this was not really available by the time that study was published. And another study that involved 3 sub-Saharan African countries, Benin, Eritrea, and Sudan. Again, beclometasone, salbutamol, and pretropin were listed. What was the availability like? It was less than 50% in the 3 countries. What of the affordability? Again, that was an issue. Now, this other study by Marsh et al. From South Africa, where they looked at 46 primary healthcare facilities, and they looked at diagnostic tests. Peak flow meter was what was available, and it was available in up to 50% of the study centers. And in a different study where spacer device availability was looked at, South Africa, 72% of the center study had spacer device, but there was 0 in Ghana, and in Uganda, adults and pediatric spacers were 18 and 19% respectively, and 20% in Nigeria. So these are things we use in thinking about management, drug treatment, pharmacological treatment. And here we're looking at sub-Saharan Africa countries and affordability and availability of some of this medication. Now back to this study, still thinking about inhaled corticosteroid and what makes us underutilize it, where we can see that in 30% of the people, they were not available. In a further 35%, they were not affordable. So what are we talking about? We prescribe this medication, we make so much noise about inhaled corticosteroid, but it comes down to sub-Saharan Africa. They're either not available, or where they are available, they're not affordable. These are things we need to look about, because when you don't provide the right medication, you give room for misconception. You give room for people to find alternative medication, give room for people to do spiritual exorcism while treating asthma. So we'll go back to another principle which Bruce spoke about also, environmental control. There is a misconception that something, it's curable, but we know that asthma is more or less controllable, and you can take steps to reduce allergy or asthma triggers in the environment, spring cleaning, reducing of dust, pollen, avoidance. Then you can go a long way to control asthma. Remember, we talked about the 4 main things: making a diagnosis or being able to use pharmacologic therapy. And here we're talking about environmental control in terms of management principle. Again, we'll go back to that Ngololo story, our little girl from Ghana. Eventually, Ngololo was noticed to be allergic to animal fur. She had received this gift on her 10th birthday a year before. And during the cold night in her shelter, which they call Mayata, she uses that her fur covers herself. And once she does, she then has an attack. After spending any night under the fur, she only got relief if she spent time away. And it coincided with the time where they took her to the healer and performed the ritual. And this was a different site from the, and it was a fur-free shelter. And so she got better until the doctors helped. And these are one of the misconceptions we need to correct. And this was then the published data. Now, still talking about that environmental control, Ngololo's zone was that of fur. And in this study, using Isaac questionnaire, where environmental risk factors for asthma in children 13 to 14-year-old African children was done. What influenced severe asthma a lot was a mom that smoked, a cat at home, having more than 3 times weekly exercise, and drinking paracetamol more than 1 time a month. So there are environmental factors, and we don't control them. We may tend to think more of the spiritual and other causes, and that will also fuel misconceptions concerning asthma management. So here again, as I try to wrap up, are some of the overlooked management principles, and we need to recap. We've talked about being able to confirm asthma diagnosis objectively using lung function tests, being familiar with your peak flow meter, being familiar with your spirometer, assessing your patient's inhaler technique each time they visit your clinic, being able to make sure they're adhering to the treatment you're giving, not just increasing or saying 2 puffs BD without really going through their adherence, and checking what triggers are in the environment so you can manipulate it, using guidelines to help assess asthma control, addressing the patient's concern, which may be beyond just pharmacologic treatment, insisting on using a spacer, especially if you're using an inhaled corticosteroid, using routinely written asthma action plan for these patients, particularly in children, but of course adults also, prescribing medications as you use. Where you need to use combination medicines, you use it, checking allergy status of your patient, giving a follow-up that is regular, that you can be able to say what is happening to your patient. That will help reduce time away from you and help reduce misconceptions about asthma management. Of course, counseling, you need to refer them. Education, go all the way. And that is what we're talking. So in conclusion, what have we really said in this talk? Our health workers, me, you, all of us need to step up our game in sub-Saharan Africa. We need to update our health workers on usefulness of objective diagnosis, monitoring, asthma tools that are required. We need to demystify use of ICS. It will help us a lot in tackling misconceptions. Our respiratory societies in different parts of Africa, we need to lead our governments. We need to update our policies. We need to look at those as essential drug lists and make sure the drugs that need to be there are on them and they are available, especially the inhaled corticosteroid. Yeah, today in World Asthma Day, a lot of companies are sponsoring. Here we have Kipla, GSK, GES, and so many drug companies. We need to draw their attention and have them have a sense of urgency to correct this availability and affordability issue of asthma drugs in sub-Saharan Africa, because it is a big issue. Then education, we need to get our people involved, get our patients involved, get caregiver involved. Everyone needs to be more and more educated. And so a day like this, many talks are out there, but even you in your own little corner, make sure you're educating people. Make sure you yourself are updating yourself. Partnership in asthma will help reduce misconception, and all the hands need to be on deck. The time to act is now. I thank you for listening. Here are some of my references.
Thank you, thank you, thank you. Nobody can fail to listen to you. That was very forceful and excellent presentation. And I'm sure now all our participants are aware of the myths, misconceptions, misinformation, mistreatment, and misdiagnosis of asthma. And we shall all do very well if you follow your instructions. Thank you very much. Again, question will come at the end of this. Now, let me give a brief moment for our sponsor, Dr. Mary Ngari, to make a few presentations.
Good evening, everyone. Thank you so much, Dr. Aloch, for the introduction. So my name is Mary Ngari. I'm the brand manager SSA at CIPLA. So I am grateful, and we are grateful to PATS for this evening as we commemorate World Asthma Day. We are glad to partner with you as CIPLA. And in CIPLA, what we say, we normally care for life. So we are caring for life. And in my presentation this evening, I'll be looking to share with you how we are caring for life. And as we have heard from our two speakers, today we're just speaking about asthma and how we can be able to care for life for patients who are asthmatics. So I want to share this slide because I'll be using two brand names interchangeably in the presentation. So you can see the flag of Kenya. This is Foralin. It is our brand of formoterol budesonide in Kenya, but we also have the same product in other parts of the continent, as coming as a brand name called Foracort. Still our brand name for formoterol budesonide. So it can be available in Tanzania. It's also available in Uganda. So I've put up these two because I'll use the two brand names interchangeably. But the doctors kindly have a look and check which brand is available in your country. So there was a fundamental change in GINA 2020 guidelines, where all adults and adolescents with asthma should receive ICS containing controller treatment. So this is a fundamental change that happened. It was an important change which happened in asthma management in 30 years. There had never been such a change in 30 years. So there was a lot of research and campaign going on for 12 years to ensure that there is that frequent use of SABAs had been checked and had been seen to increase the risk of severe exacerbations. So that is what led to this fundamental change in the GINA 2020 guidelines. So as CIPLA Respiratory Solutions, we are so proud to provide you with a solution that will help you meet the GINA 2020 guideline objectives. So when we look at the recommendation by GINA guidelines in asthma management, so number one, they recommend that their interventions should be able to reduce the risk of serious asthma-related exacerbations and death, then simplify and allow for consistent messaging about the asthma management, and also it should be able to avoid establishing a pattern of patient reliance on SABA early during the disease. So this is what we've spoken about in terms of the change that happened in 2020. So I said I'll be interchanging between Foralin and Foracort, and so you can note that depending with the country you are from. So Foralin contains budesonide, the inhaled corticosteroid that helps reduce inflammation in the lungs, and also contains formoterol, that is the long-acting beta-2 agonist, that is the bronchodilator, which has a peak onset of 1 to 4 minutes, and this can last up to 12 hours. So the quick onset of formoterol and even is the one that allow it to be used as a reliever. And as we said, as we looked at the change that indicated the overuse of SABA, this was one important benefit of formoterol that was that determined its use as needed. So Foralin or Foracort, it can be used as maintenance and reliever therapy, and it will help you as a healthcare provider to be able to help your patients to reduce the risk of serious asthma-related exacerbations, simplify and allow for consistent messaging about the aims of asthma treatment across the whole spectrum of asthma severity, avoid establishing a pattern of patient reliance on SABA early in the course of the disease. So this is the recommendation as per GINA. So as I have mentioned, formoterol budesonide has been recommended in GINA 2020 at every step of asthma management. And so by initiating Foralin as a reliever to your patients, you significantly reduce the risk of severe exacerbations. And this was seen in the SIGMA studies. So when you look at every step, the step 1, 2, 3, 4, and 5, in step 1 and 2, Foralin or Foracort can be used as needed low dose, or as there is the recommendation in step 2 of daily low dose ICS. This is in adults and adolescents. In step 3, step 4, and 5, it also can be used as for maintenance, but still as a reliever option, it has been provided. Foralin or Foracort has been provided depending with the strength. So you can, the ICS requirement in a day could be between 200 to 400. That is the low dose as has been recommended by the GINA guidelines. So when the patient is looking for a higher dose, then that would be at step 5, and that would be greater than 800 micro CG in terms of the ICS requirement. So what I would want you to remember is that we have provided you, and we are caring for life as CIPLA, providing you with Foralin and Foracort, which can be utilized by your patients in every step of asthma management in the SMART therapy as a single maintenance and reliever therapy for you. So kindly pass those benefits to your patients. So this is a study in which one arm, the orange arm, was put on same maintenance dose of ICS and LABA, and then they were also on a reliever, which was the short-acting beta agonist, the SABA. Then the red arm was the formoterol budesonide put on SMART therapy. So as you can see, in the patients who are on step 2, the patients who are on step 3, and those that were all in step 4, one thing that you're able to see when you look at the left-hand side in terms of exacerbation rate, that was able to be seen. There was a reduction in all the patients who are in step 2, step 3, and in step 4. So as the heading there is that formoterol budesonide SMART will significantly reduce the rate of exacerbations for your patients at step 3, step 2, 3, and 4 of asthma treatment. So with Foralin and also Foracort as a SMART therapy, you will be able to meet both your patient's needs and your needs as a healthcare provider when you're able to reduce the rate of exacerbations for your patients, and even reduce the over-reliance with SABA in ensuring that they don't suffer the serious adverse events that would come with over-reliance of SABA, the patient having the over-reliance of SABA. So having spoken earlier and said that we have Foralin in Kenya, we have Foracort in Uganda and Tanzania, I would also want to mention that we have other ICS LABA medications as CIPLA as we continue to care for life. So in Zimbabwe, we have Serocort. It's our brand of salmeterol-fluticasone propionate. And with the science behind salmeterol-fluticasone, it's that there is synergy between the two molecules. So this is what we are providing to you as CIPLA, the synergy to celebrate life. So this can be used in asthma and COPD. So we have two strengths, the Serocot 250 and also the Serocot 125. So I would also want to mention for anyone else who is watching or listening to this webinar from any other part of Sub-Saharan Africa, even if we are not yet there, we will be coming soon, and so that we can be able to pass the benefits of our brands and our products to your patients as we continue to care for life as CIPLA. So just a reminder also in terms of where salmeterol-fluticasone can be utilized, even though it cannot be utilized as a smart therapy, Virginia guidelines, as Dr. Adeze has spoken about it, recommends in step 3 and step 4 the use of ICS LABA also. So this salmeterol also has its place, and for patients who are in Zimbabwe, this is also a place where patients can utilize Serocot. So just want to make a reminder of the strengths that we have in Kenya. So we have Foralin with a dose indicator for compliance for your patients. We have both the three strengths, the 100, the 200, and the 400, and all have those indicators. So you can recommend this for your patients. Then in Uganda and Tanzania, we have Foracot, and in Uganda, we have still 3 strengths, the 100, the 200, and the 400, and with a dose counter also to help in compliance for your patients, to check compliance with your patients and adherence with the medication. Then in Tanzania, we have 1 strength, which is Foracot 200. So as I conclude, I would want to mention that Foracot, the simplified asthma management as per GINA 2020 can be met with Foracot or Foralin. And we are requesting you to choose SMART, and you choose Foracot and Foralin and pass those benefits of those products to your patients. Thank you so much for your time. And thank you, Dr. Alwech. I take it back to you, the program back to you.
Thank you, Gary, for helping us celebrate life. And now, without much ado, I'd like to hand over to the session chair, Dr. Annie Rungu, to take us through the remainder of the session. Dr. Annie Rungu.
Thank you, Dr. Alwech. Bruce, Mary, those were very great talks. Thank you for keeping time. And I'll just start quickly with the Q&A. Some questions have already been answered in the chat box for the question and answer, so you can check there. But I'll throw this first question at Bruce. Paul Kalan has stated that the new ERS guidelines talks about spirometry, bronchodilator reversibility, and FeNO for diagnosis of asthma. Is this practical in Africa?
Thank you. I think very, very practical, but requires a bit of effort. We are doing it here in our practice. We have a FeNO machine and we have spirometry. If people cannot afford standard spirometry, you can use the portable spirometers and be able to integrate this in your service.
Thank you. Adad, the next question is a combination of 2 questions about diagnosis of asthma in a child below 5 years and in an infant. Are you able to objectively diagnose asthma in this age group of infants to 5-year-olds?
Okay. Thank you for that question. It is an important and interesting question that keeps resonating. Yes, it's possible, but the thing is that is it sustainable, because there are infant lung function, which are more for research purposes. So asthma in the younger age group is more of a symptomatic, because NAPEP guideline also helps you to use certain questions. And so when you have certain personal and family history and personal history of atopy, and then this child is able to respond to either your salbutamol and then subsequently trial of ICS, you can be able to make that diagnosis. without having to rely, because children less than 4 years may not be able to give you a good blow on either peak flow or lung function, even though you keep training them. But there are infant lung function and other ways of doing lung function that is not spirometry. But they are not usually on regular day-to-day use in clinic. Most times they are for research purposes. So the answer remains yes, you can objectively do it, but is that a sustainable pathway? The answer is no. In children particularly, you use more of clinical symptoms to make up your mind, and then maybe drug trials, which is also within the GINA guideline. A response to these trials can help you make up your mind what you're dealing with. Remember, once a child is less than 5 years, all that wheezes is not asthma. So you need to also look into, is it just asthma? Or there, viral, bronchiolitis and other causes of wheezing and fast breathing? That's the way I'll look at that question. Thank you very much.
Thank you, Ada. In Kenya, we are revising our asthma guidelines, and one of the things that we are recommending is if you find a child who's below the age of 2 years and you're uncertain about the diagnosis, one of the options is refer to a specialist, and that specialist can be a pediatrician or a chest specialist if you're in a center where they're available as an option. But otherwise treat based on clinical symptoms and signs, and for the most part refer when you're not sure. So my next question goes to Bruce. Bruce, this is a question. So the first part is, what's the guideline on oral bronchodilator use for asthma?
The oral bronchodilators are no longer recommended for use in the treatment of asthma, whether children or adults, including syrups. However, if you are in a part of the world or country, and that is the only medication that you have, please go ahead and use it. Do not leave someone to die, because part of what is taken orally will finally reach the airway and help this patient, but they are no longer recommended for treatment of asthma.
What is the recommendation on the use of injectable steroids in managing asthma?
Injectable steroids is part of systemic steroid. The need to use an injectable steroids is very rare. Oral systemic steroids are good enough. However, in severe asthma, which is treatment resistant, where high doses of oral steroids are given, injectable steroids like methylpred can be used as a monthly depot to relieve the patient from loads and loads of prednisolone. Injectable steroids, for example, hydrocortisone, could be used in patients who are unable to swallow during a bad asthma attack. But doctors should take time to check the conversion table, which we use. For example, 40 milligrams of prednisolone could be equal to many milligrams of hydrocortisone. The tables are available, check the conversion and give the right dose.
Right. On the same thread of steroids, can we use inhaled steroids during flare-ups and when?
Oh, can you repeat that?
Can we use inhaled steroids during flare-ups and when?
Yes, very excellent question. During flare-ups or attacks, we use a combined strategy of a systemic steroid, like I mentioned, usually oral prednisolone or an injectable hydrocortisone, and overlap this with good and adequate doses of inhaled steroids. It sounds illogical, but that's what we do. Initiate the patient on the inhaled steroids and overlap it with the systemic steroids. Very good strategy. When you stop your systemic steroids, probably 5 days, then the patient will continue with the inhaled steroid.
Right. And also within the GINA guidelines, they're using it for both control and for relief in certain steps, right?
Yeah.
Third part of the question, what is the role of leukotrienes in bronchial asthma? And what point should they be introduced?
Leukotrienes modifiers are very important in the treatment of asthma. However, we consider them to be add-on therapies. Once you have started the other treatment, you can add your montelukast in there as an add-on. There is a subset of patients, most of them I've seen are females, who do very well on only montelukast and they won't need the steroids. This needs further research to understand, but it has been observed and other pulmonologists have reported the same.
Permit me to also add something to that. Remember, we talk about the United Airways. So you have asthma also occurring concomitantly with other allergic things, especially if it's the eosinophilic asthma, the IgE mediated. So you may have allergic rhinitis and some of the atopy-related diseases occurring. So even in such patients, the montelukast, which is a leukotriene antagonist, also helps to also keep those symptoms under control, because some of them can serve as a trigger for the asthma. So the montelukast becomes also useful, not just even as an add-on, for those who you have allergy as part of their presenting complaints or their story, then the montelukast also is very useful in them, particularly in children.
Right, and lastly, in addition to that, it's also recommended as an add-on to your corticosteroid, especially for adolescents and women who have symptoms that flare up during their menstrual cycle. So it's good for catamenial, as an add-on for catamenial symptoms. Dr. Loach, our resident infectious disease expert, are you still with us?
Yes, I am, Anne.
The next two questions are yours.
Oh, okay, go ahead.
What can you do to increase safety in nebulizing COVID positive patients?
At the moment, if you have to use nebulizer, you prefer that the patient has got her own nebulizing machine, not the old way where they used to share the nebulizing material. The other thing is you have to find out which room they're using, and it's recommended that if they're in their own room, use that room, nobody should go there for a couple of hours after they've nebulized, because the environment, and we're not so sure that COVID is a droplet spread, so you're like airborne rather, so you're likely to find it in the environment for a long time. So you recommend each individual to do it on their own at home at the moment. There's no other way of, but if you can do that, it's much better. But if you have to use it, then you have to take those precautions to avoid any airborne spread.
Right. The second question, Dr. Loach, is can inhaled corticosteroids be used in an asthmatic diagnosed with TB? Is it safe?
Yes. There was a lot of misconception about the use of steroids in that flare up TB. No, it's very safe. If you need to use it, it's safe.
It's safe. All right. The other question was about, I passed it. Are inhaled corticosteroids safe to use in pregnant women?
That's always been the question, but largely it can be used with caution, but it is fairly safe. So far, there have been no major reports of serious effects, but maybe Bruce Krenga can give us more. He's doing more research, whether lately they found any serious events with use of it.
Yeah. Yeah. Dr. Loach, I'll ask you then another question. Are inhaled corticosteroid, nebulized, sorry, corticosteroids still used in the management of asthma?
Not routinely. It's been found that they really don't or confer much benefit in the management of acute asthma. In fact, it's been discouraged in most guidelines.
And how about Ada?
Sorry?
Ada Ayuk?
I can't hear you.
Yes.
Dr. Ayuk?
Yes.
This question is to you. Can mast cell stabilizers be used in the management of asthma?
Yes, they can, like the Zaditan and all that. Yes, they can, but all these are add-on. Remember, asthma is mainly an inflammatory problem. So the bane of asthma treatment remains anti-inflammatory. So inhaled corticosteroid, and when it's an acute state, you may use your oral corticosteroid. That's why, during my talk, I said, keep your eye on the money. The money here is steroid. So every other thing is add-on and useful if you also have atopic asthma, because the other United Airways can be affected. So yes, they can be used, but they are not the bane of treatment. And that needs to be understood so that we can have less of steroidophobia and less of misconception concerning asthma management.
Right. Well, I'll give you an example. In Kenya, they're not, I don't think available anymore. Your chromones and are not available anymore for most people.
I think by and large, they've been discredited. And if you remember, Altran, who actually introduced them, committed suicide because his drug did not work very well and was discontinued before. It started very well with a lot of good reports, but soon it was realized that it was not better than taking a teaspoon of honey. So most people discouraged it. It was too expensive, and a lot of parents, particularly in children, the parents were being given the wrong assurance that the medicine was good for their children. It was mainly used in children, but I think now I don't think we need to use it.
Right.
These are gone. Okay.
Yeah, and they're not cheap. Any evidence, Ada, this is to you, any evidence on dairy, wheat, and other dietary products that are linked to asthma exacerbations?
Okay, thank you for that question. We know that, again, allergic asthma goes through a lot of pathway, IgE, and we saw that graph, the photograph that Bruce had shown us. So you have interactions, you have triggers, and some can be linked. That's why if you saw part of the management principle, you need to check the allergy status of your patient. So sometimes they may be food allergy, there may be aeroallergens that all lead to that pathway and then trigger asthma. So sometimes you need to find out specifically, not all patients would react or have that pathway. You need to check what exactly your patient reacts to, whether a food allergy, whether an aeroallergen. So yes, it can be linked, but not for all patients. So you need to assess each patient individually and be able to check their allergy status. Skin prick tests will be able to help you. Food allergy tests will be able to help you. I remember there are also differential diagnosis of the complement pathway, the C2, the hereditary angioedema, and all that. Some of them can have some of those pathways. So sometimes you may need to check the complete status of your patient to be sure what exactly is going on. But as for being a trigger, some of that can be, but not for all patients. And the test needs to be done to be sure which patient is involved.
Dr. Ayers, despite all this accumulated evidence of the use of this allergy skin tests and anti-allergy treatment, I find them expensive, and I find them probably superficial in both senses of the word. Because I'm not, although I don't do much in children, but the few I do, I haven't found much. I haven't found them cost effective. That's all. They may be effective, but I don't really want the cost.
Of course, I do it, and I've seen it being very useful. Some parents come to you really worried. So if you just tell them, oh, avoid this and avoid that, some really want to know what exactly is the trigger. And if you have access to that, it becomes a very useful tool in the hand of those that need it. I agree with you, maybe not all that need it, but the few that need it has been quite useful, especially in my practice. And that is my experience.
But in some cases, you find them allergic to 101 things and something they don't even come into contact with.
No, not necessarily. Some have been mono-sensitized. And then in those ones, you can actually chase down whatever it is. So maybe multiple sensitization. And everything has its predictive value, positive predictive value, negative predictive value. But it begins to give you a sense of what to do rather than give a blind, general advice. It becomes another objective tool. Just like saying in the hands of the pulmonologist, oh, you don't really need to do spirometry. You can get a history and know what's wrong with them. But a certain lung function you do until you do it and see how the FEV1, FEF 25 to 27, and FVC is playing out. Then you may not be able to give a proper diagnosis of what is wrong with the patient. So I have personally found use of allergy skin prick test useful in my practice. So for those who I begin to see that need it, I ask them to do it. It's not that expensive. There are many more things they spend money on, and finding out how to help the health of their children and of even the adults has been quite useful, especially in my practice.
Obviously, I can't convince you otherwise.
Yeah. What I will tell the audience is have a look at the article Bruce posted about the African Severe Asthma Project. The phenotypes and the more detail will tell you the common allergens that we have in Africa, in Africa. And maybe that can guide you in managing a patient when you don't have access to allergy testing. But it is quite useful, especially in the pediatric population. So Salu says—
Personally, I've also published a lot of works on that too,
yes,
and I found it
yes,
quite useful.
Yeah. So next question, Salu says that as Africans, our asthma phenotype and determinants may be different from other parts of the world, as well as their affordability and availability of medication. What's the best way to optimize asthma management for Africans? Dr. Lwach, you want to take this one?
Dr. Bruce will do that.
What's the best way to optimize asthma management for Africans, both Bruce and Ada?
What I think is, when we talk of phenotype, doesn't mean that Africans have a different phenotype. The eosinophilic, the neutrophilic, and the other are available or are possible in Africans and non-Africans. What we need to do is speak to the people who make these medications and see how they can help sub-Saharan Africa in terms of affordability, and because make the drugs available. The pathophysiology is not different on how asthma occurs. So availability and affordability still remains the bane of thing. It's not that in Africans, they don't have the same phenotype. It's the same pathophysiology. So if you find someone who has need for steroid, they're the people who are involved in making this subsidized, whether by foundations, whether by whatever. We need to speak to the drug companies, make these drugs available, make them affordable. We don't change our pathophysiology because we're Africans. Asthma is the same way, it will appear the same way, the same age group cutoff that behave in different ways. So phenotype doesn't necessarily mean in Africans, because we're Africans, our gene says, it's a different path. The pathophysiology comes down to the same thing. So the only answer is making those drugs available and affordable. So we speak to Kipler, we speak to GSK, we speak to GES, we speak to all the people who make these medications for Africa and see how they can help us and help our essential drug list too.
And I think the most important thing, because all this information already as known overseas is also known in Africa about asthma. So what we need to do is really educate not only the patients, but the health workers. We know very well that we've done this work before. The point that causes suboptimal control in Africa, you can put them in four groups. First is the patient themselves, their knowledge, their attitude, and which we are addressing today in the bit. Secondly is the doctors, also their knowledge, and they are able to, spare a lot of time to explain to the patient, educate the patient. So a lot of doctors prescribe medicine for the patient, but they don't explain to them what to do, and they're not even sure. And thirdly is healthcare facilities, making sure that the drugs are always available. And fourthly, of course, making sure that patients can access the healthcare facility, the geographical things. These are the four things that we've done several times for many years, and all other theories must at least fall in these four groups to improve asthma control in Africa. There's nothing about the genotype or phenotypes. Those are not going to improve the control in Africa. It's making available. Okay.
Bruce, are you with us? Bruce?
Yes, I'm here.
This, I'm about to finalize the Q&A session. So this last question goes to you. And what is the role of magnesium sulfate in the management of acute exacerbations or in the management of asthma?
Our studies actually found infusions of magnesium sulfate useful, but the side effects, the accessibility, and the coming on board of other more effective and easier treatments have made the use of this drug unfashionable. If you have someone who has a severe asthma attack with the respiratory failure in ICU on a ventilator, you could actually give them infusions of magnesium sulfate. But with availability of other treatments, this is never needed.
All right.
I beg to differ just a bit. Even in the
Yeah.
GINA guidelines, at the point where you've gotten to severe asthma that is recalcitrant to back-to-back nebulization, and this patient before you, your two options, which GINA still opens up, are use of aminophylline and use of IV magnesium sulfate in 20 mils of normal saline, give it over 20 minutes. So in pediatric practice, it still becomes very useful. When you've come to that end of the road, where you now have to open up to use of aminophylline, magnesium sulfate for that severe acute asthma that is not responding, is still very, very useful, particularly in pediatric practice.
I think we must take guidelines as guidelines. They are not kind of Bible truth that must be followed. They only need, if you know what to do, if you're stuck, that's when you need a guideline. But otherwise, if you know exactly what to do, you don't even need the guidelines.
Yeah, I quite agree with you, Joe. Yeah, guidelines are guidelines, but that's why they also guide you. When you get to that end and you use back-to-back NEPs, you've gotten to that point. The saturation is still dropping, and you've used ipratropium, you've called in your steroid. Aminophylline still comes useful, and magnesium sulfate IV in that dose I've just spoken about also comes in useful. Actually, it's how the patient just last week.
Yeah. So for both medications, insulin, magnesium sulfate, it's advised that they should be used where you can have proper cardiac monitoring. So they are best used in an intensive care unit. You can start the initial dose in the outpatient, but again, you must be in a center that you're able to monitor that patient closely. And magnesium sulfate and amylin, for most countries, it's part of the WHO essential list. It's available in most countries because magnesium sulfate is used as a tocolytic for obstetric complications. Therefore, it's an easily available drug and very useful in severe asthma, but it has to be done in a place where there's proper monitoring. So don't just use it blindly. That's the take-home message. And then the final thing is to CIPLA. And by CIPLA, we mean all the pharmaceuticals that supply our asthma medications. Within the chat box, the Q&A box, quite a number of comments are about affordability, availability, and accessibility of medications. And what most of the audience is saying is that needs to improve, and there have to be measures that the pharmaceutical companies make towards making these drugs available, affordable, and accessible. So Mary and team, if there's some, and your team, if there's something that you're doing to improve that, it'll be nice you can email and we can forward it through Pat to the rest of the group. So I'll just like to close the session. Thank you all of you for joining us today. You've made World Asthma session and webinar quite interactive. We have on the PATS website, go to the website. If you're not a member, you can register under how to join as a member. You'll find a link there, and our admin is very resourceful. You can email her any issues. We also produce a journal, and the main issue is is out, and there's two very interesting articles that have been highlighted to see. So we'll request that all of you, again, through our website, have a look at the journal for the Pan-African Thoracic Society. And finally, I'd just like to thank again our sponsors, Mary, Sipla, Ada, Bruce, Dr. Loch. Thank you very much for making today's session a very interactive and useful session. And I'll just like to bid everyone good night, and join us for our next mini symposium in June. Watch out in your email for the notices for that event. Good night, everyone.